Good evening, everyone. Welcome all for Indian Institute of Homeopathic Physicians Delhi State Branch webinar for the June month. We have with us Dr. Kavita Kakkar, a very dedicated homeopathic doctor in Delhi. She's committed to enhancing overall well-being of patients through her brilliant homeopathic assessments and lifestyle counseling. She has a Master of Science in Counseling, Family Therapy, a postgraduate diploma holder in Integrated Geriatric Care, also a diploma in acupuncture. She has presented research papers on role of homeopathy in iatrogenic disorders, Alzheimer's disease, also in mediation in depression. Please welcome her to enlighten us on today's topic, role of homeopathy in geriatrics. Welcome, Dr. Kavita. Now you can.
Thank you,
Yes.
Dr. Mrinalini. First of all, I would like to thank Dr. Mrinalini, Dr. Geeta Mungia, and all the team of IIHP for inviting me on this platform and giving me a chance to speak. And मतलब मैं अपनी नॉलेज जो मैंने देखा है बूढ़े लोगों को वो शेयर करने के लिए आई होप फ्यू थिंग्स विल हेल्प अदर्स ऑल अदर्स। वैसे तो मेरे टीचर्स बैठे हैं, मैंने ही उनसे बहुत कुछ सीखा है और अभी मुझे लग रहा है कि मैं अगर कहीं कुछ गलत करूं तो प्लीज सर और जितने भी मेरे सीनियर्स हैं मुझे प्लीज एक्सक्यूज मी फॉर दैट। माय टॉपिक टुडे इज कॉमन जीरियाट्रिक डिसऑर्डर्स एंड कहाँ गई कॉमन जीरियाट्रिक डिसऑर्डर्स और an overview dementia and its homeopathic management. First of all, I think elderly में होम्योपैथिक मेडिसिन का बहुत रोल है क्योंकि ऑलरेडी बहुत सारी जो है बीमारियों से वो लोग सफर कर ही रहे होते हैं और कई बार पॉलीफार्मेसी हो जाती है। तो अगर कुछ सिंपल चीज़ों के लिए जहाँ अगर होम्योपैथी हेल्प कर पाए तो बहुत अच्छा है। दूसरा, जैसे जैसे पेशेंट को डिमेंशिया होता है या मेमोरी लॉस होता है, दे आर नॉट एबल टू टेल देयर सिम्टम्स, दे आर नॉट एबल टू टेल व्हाट दे आर फीलिंग, कहाँ पेन है, क्यों दिक्कत हो रही है। ये बहुत कुछ हमें डॉक्टर्स को ही जज करना पड़ता है कि अगर ये पेशेंट ऐसा बिहेव कर रहा है या खाना नहीं खा रहा तो क्या क्या प्रॉब्लम्स और हो सकती हैं। First of all, I would like to define aging. It's an inevitable process. It is the chronological age of a person, means number of years a person has lived. And persons of age more than 65 years are considered as elderly. According to WHO, persons who have attained 60 years or above are senior citizens or elderly. Young old are between 65 to 75 years of age, and middle old are 75 to 85, and oldest older are 85 and above. Now, why there is a need for a specialized branch like geriatrics? Because elderly population is increasing due to increase in life expectancy and decreased death rate due to the improved medical facilities, improved labs, and improved techniques which can help in considering all those issues which the elderly suffer. So it's a medical specialty which focuses on providing care for unique health needs of older people and want them कि they should be independent and maintain their health for as long as they live. The need for this is this is the data, and we all can see that by the year 2050, the number of living elderly people will almost double who are living by 2019, and elderly women will increase more in number, and life expectancy will reach by 75, which is around 68 years in 2019. Now, these are the common physical or disorders which are seen when we are taking care of elderly, and most of us know about this: just COPD, chronic bronchitis, malignancies, heart diseases, certain chronic diseases of kidney, then diabetes mellitus, ischemic heart diseases, joint problems, arthritis, and osteoporosis, hypertension. hyperlipidemia and atherosclerosis. Some may suffer from stroke, some autoimmune disorders, fractures, visual disorders, and hearing loss. And a few mental disorders are dementia, Alzheimer's, depression, anxiety, and sleep disorders. Challenges which are faced by elderly are ageism. Ageism means generally all the society members who are younger, yeah, less than 60 year of age, they sometimes feel कि elderly तो इसी तरीके से ही behave करते हैं. There are certain myths about them कि they are of no use, yeah, they will get irritated easily. This is because generally they lose the purpose of living. They get retired, yeah, they are not involving themselves in the other activities which they used to do during the young age. Lack of physical infrastructure, then insufficient financial support. Sometimes there is loss of some business, yeah, loss of job due to retirement. Then there is rapid decline in socioeconomic supports, inadequacy of companionship. This may be because of loss of spouse. Then certain mental health issues may be there, and emergency response services still are not very high in India. Now, dementia occurs because as we grow, there is some shrinkage in the size and weight of the brain. This is normal. Some physiological changes are always there, but dementia is a syndrome due to disease of brain, usually chronic or progressive in nature, when higher cortical functions, including memory, thinking, orientation, comprehension, calculation, learning capacity, language, and judgment, all this is disturbed. There is deterioration in cognitive function beyond what is expected at the biological age of that person. Social abilities are also disturbed and they interfere with activities of daily living. Now, cognitive symptoms are memory loss. The person may find it difficult to communicate, like naming a fruit or vegetable. He or she may forget the name of the person's. Then, visual and spatial abilities, such as getting lost while driving. Uh, the person may not able to tell what time of day it is. They may not be able to tell what is the weather and what is the date. Difficulty handling complex tasks, example addition and multiplication. They may have difficulty in planning and organizing, which they used to do earlier in their life, and difficulty with coordination and motor functions, confusion and disorientation. Psychological changes may be there may be some personality changes, depression, anxiety, inappropriate behavior, paranoia, agitation, and hallucinations. Now, these are the physical changes. Initially, mirror changes are there. Mirror changes mean the person is not able to recognize himself or herself when he or she looks in the mirror, unable to recognize his near ones and dear ones, the family members, unable to understand or express language, unable to attend meaning of sensory impressions, not able to do mathematical calculations, and even writing or reading may be affected. They may have shuffling gait with generalized muscular rigidity. Now, this can be because of Parkinson's. Uh, Late changes are mute and unresponsive, little or no response because of decrease in diet, and the patient may not be able to tell he or she is hungry. So, there is loss of muscle mass and emaciation. Incontinence of urine and stool may occur, and the person is incapable of taking care of themselves, may present with epilepsy, and later the patients become bedridden with extreme psychomotor retardation, and they are very prone, very susceptible to injuries due to falls. Now, this is the etiology. Alzheimer's disease, multi-infarct vascular dementia, Parkinson's disease, AIDS, dementia complex, multiple sclerosis, infection, late stage of syphilis, exposure to toxic substances, जैसे कि exposure to lead the person who are painting, yeah, they are working near coal mines. Vitamin deficiencies, then toxicity of prescribed medicines and certain cancers. Pathological changes, these are the lesions. Amyloid plaques can be seen in PET scan. Uh, and then there is a negative lesion, neuronal and synaptic loss. Hippocampus is affected, which supports memory, learning, navigation, and perception of space. Now, question is dementia hereditary? Majority of them are not. Rare types may be inherited. Now, this Alzheimer's and may be inherited when gene APOE4 is present. 3 single gene mutations may be the responsible for early onset Alzheimer's disease. They are amyloid precursor protein on chromosome 21, preselin 1 on chromosome 14, and preselin 2 on chromosome 1. Investigation which have to be done are mini mental test score, then measurement of activities of daily living, and IADL. The blood tests are CBC, kidney function test, liver function test, VDRL, ELISA for AIDS, serum electrolytes, sugar, thyroid profile, ECG, color Doppler, CAT scan, MRI, and PET scan. Now this mini mental test score, they are fixed. You can download from internet. Anybody can download and can score easily. Physical challenges with dementia are patients may show anxiety, agitation. They may be assaultive and show restlessness. Then there is apraxia, aphasia, delirium, delusions, depressions, hallucination, paranoia, sleep disturbance, sundowning, verbal noises. Now, challenges with dementia are environment. First one is environment. Environment may be too large. The person become more anxious, restless due to this. Too much clutter or congested space. If the room is too full, even then they can be restless. No orientation and no interest. Poor sensory environment, unstructured environment, and unfamiliar environment. These all are the challenges which are faced by persons who are suffering from dementia. Challenges of dementia related to task and communication. If you ask that person to do something, he or she may feel the task too complicated. If it requires many steps, unmodified tasks they cannot do, unfamiliar tasks which they have never done in life, it can't be done. Communication may be difficult with the elderly. They may have hearing loss. Vision may be disturbed due to some retinal changes or eye or maybe cataract, and balancing may be disturbed. Associated medical problems are effects of other medication, impaired vision and hearing, acute illness, chronic illness, dehydration, constipation and impaction of stool, depression, fatigue, and physical discomfort. Now, management of combativeness reasons are not able to dress or bathe or eat, may be tired, may have pain. It may be effect of sedatives. The environment may be unfamiliar or poor communication. Actions are look for the cause. Don't take aggression personally. Avoid teaching. Distraction may help. Be conservative. Experiment with music and restructure the environment. I have seen my patients who are having hearing loss, and if they are given hearing aid, they become restless because the sound of hearing aid, even the sound of fan becomes too noisy, and they find it very difficult when they are in a group. They find it difficult and they don't feel like using hearing aid. They rather prefer not to use it. So slowly they become dependent on the others. Others, they don't feel like going out because they feel ki they will not be able to understand what others are talking and what others are speaking, and they will not be able to tell what communicate properly, so they become isolated. Now, there are certain issues with eating also. जैसे physical difficulties, जैसे loss of tooth या toothache या decreased salivation. There may be certain chronic diseases, agitation or distraction, uh, change serving style, and problem in deglutition, choking of food in throat or windpipe. There may be certain visual problems because of lack of salivation and decrease in taste, but they might not find food tasty. And because of loss of cells in the nasal cavity, they may not able to smell it properly. And in dementia, they may forget to eat food, and many a times it happens they may demand again. They forget them if they have eaten or not. So action is offer nutritious meal at regular time, provide a minimum distraction environment, give one utensil at a time, avoid sharp instruments, give soft or semi-solid diet, and the caregivers and family members should learn Hamilit's maneuver, so that if there is some choking, yeah, difficulty in deglutition, they are able to solve it. And don't serve very hot food, give low calorie snack. Now the environment uh, जो है, it is responsible for many accidents and falls. And in dementia, unfamiliar environment, the patient become restless. Disorientation, confusion due to overstimulation may be there because of too much noises. Person may become hostile and worried. The actions which has to be done are focus on consistency, use colors and contrast so that they can see the uneven space. The floor should be non-slippery. Limit distractions. Consider special furnitures, and beware of plants, pets, and rugs and cords, and even small children. Well, while they are walking, they should not come into way, because this is a major reason for falling. Medication effect, distinguish between a drug and a behavior symptom. Keep a record of dosage of all the medicines. Be candid and direct. Stay organized. Be prepared for emergencies. Keep a list of all the medications and regular discuss with the doctor. I'm audible now, Dr. Mrinalini?
Yes, yes.
Acha. One example, abhi recently I have seen a patient who got a ulcer on her big toe because she was diabetic and she got some injury on the foot, and she was prescribed, well, the nail was removed, and then she was prescribed some antibiotics. And due to those effect of those antibiotics, she started having diarrhea. She didn't bother to consult the doctor, and what she did is she then asked the chemist and कि मुझे diarrhea हो रहा है and give me some other medication. So that chemist, he sent some antidiarrheals and some other antibiotics instead of giving a probiotic. And when she consulted me, I have not scolded her, but I said, you must have talked to the doctor before adding one more antibiotic. So you have to be very careful while treating elderly, because वो छोटी सी भी चीज हो जाए तो वो चाहते हैं बस तुरंत it should be fine. Hallucination and delusions may be there. Hallucination is a false perception of objects or events that are involving senses, sight, sound, smell, touch, and taste. A delusion is a false idea, belief, or altered reality that is persistently held despite agreement to the contrary. Now, the actions which has to be given is request medical guidance, respond with cautions and offer assurance, use distraction, be honest, check for reality of situation, and modify environment. Safety of the patient is a must. Any harmful substance used for cleaning, example is disinfectant, bleach, phenyl, can be consumed in if a patient is having dementia. Medicine may be taken twice. The caregivers have to lock on doors. Sharp instruments and weapons have to be removed. Eatables should be kept in refrigerator always. Sleepers, slippery floors for bathrooms should be avoided. Then driving should be avoided. Clutter in pathways, cable and small furniture should be avoided. Pets and small kids standing in the way should be taken care of. Safety measures are keep substances out of reach, count pills, keep them in pill case, remove locks, keep all dangerous equipment in locks, keep fridge, check for rotten food, avoid driving, use public transport, clean spills, secure flows by tacking or taping, remove obstacles, covering cables that cross walkways. I think I should add one thing ki, homeopathy is very helpful in persons who are having dementia, because even if they take a dose twice, or even if they forget to take, at least there will be no side effects. So that is a positive thing for homeopathy, which I find. Sexuality, the patient, because they are not able to understand what they are doing, so they may show bold behaviors. They may take off their clothes in public, or they may start doing behavior which is socially inappropriate. They may flirt, forgetting their marriage. They may forget social norms and take off clothes in public, so may be suspicious or jealous. Actions are explained about dementia and involve friends and neighbors. Change and adjust clothing by adjusting dress backwards, pants with no zippers. Look for reasons behind the behavior. Try to calm down by distracting and appropriate physical contact by patting, hugging, or increase levels, anxiety of like levels. Sundowning. Now, sundowning is a behavior which generally occurs in late afternoons or evening. The person may be demanding, may become restless, may become more suspicious, is upset or disorientated. Now, this may be because of the light changes or certain hormonal changes during morning and during the evening times, which are physiological. Now, reason is dim light. They may be confused or tired in the evening. So, caregivers may communicate stress and fatigue. Make evening hours less hectic. Schedule appointments, bath, etc. in the morning. Provide regular activities. Discourage napping during the day. Reduce food that have caffeine. Reduce level of noise. Control number of visitors in the evening, and avoid alcohol and smoking. Shadowing and wandering. Shadowing means the patient may follow the caregiver. They may talk to him, they interrupt them, they ask questions repeatedly. And this is very, I think, tiring for the caregiver and very hectic. They may feel very irritated why this person is and always after me. Now, patients may walk away from home or well known path or area. Reasons are stress, time confusion, restlessness, fear. It may be because of hunger, feeling too hot or too cold, feeling urge to avoid urine or stool. So the caregivers have to find the reason why the person is behaving like this, keep the patient occupied, provide reassurance, take safety measures for hazards around the houses as water bodies, pools, steep stairs, road traffic, high balconies, place locks on the door or camouflage them, use night lights, put gates on the staircase. Bathing. Now, loses desire for taking a bath, may feel embarrassed over getting undressed, fear of running water or mirrors, may feel ill because of some infections. Water may be too hot or too cold, confusion over tasks as filling buckets. Prepared room to be comfortable and warm and non-slippery. Fit supporting rods near commode or bathing area. Check for temperature of water. Showers may be frightening. Then maintain routine. Instruct to clean folds of upper arm, under breast and legs. Check for cleanliness, washing, soap, and dryness. Hygiene is very important. The persons may have difficulty in sleep. Now, patients may be restless at night. This is very exhausting for the caregiver who has been working throughout the day, and at night, when the elderly they become demanding. Discourage what can be done is discourage sleep during the day. Involve patients in walking and physical activity. Make patients comfortable at bedtime. The area should be familiar. Avoid coffee, tea, alcohol, and smoking, and always look for that the patient may not be hungry. Clothing and dressing. Person may not be aware and may take off their clothes, not recognizing public spaces. Difficulty faced when motor skills and balance is affected. Difficulty in recognizing clothes according to date, time, and season. May be troubled by temperature, privacy, loud noise, poor lighting. May not be able to recognize clothing, might not be able to button off and close zippers. So actions is lay out clothes according to season, allow favorite outfits, use Velcro tapes, avoid zips, button, hooks, use skin-friendly, soft, lightweight fabrics, encourage wearing shoes instead of slippers. A person may face incontinence because they may not be able to tell the urge for stool and urine. So reasons they may be it may be physiological, but certain medical reasons can be there. Just infections, BHP, prolapsed uterus, diabetes, Parkinson's disease, stroke, RA, osteoarthritis, which may limit mobility. The person may be dehydrated. It may be certain effect of medications and certain environmental factors. Sometimes because of loss of memory, the person may not be able to find the way to bathroom. They may forget where the bathroom is. I have seen one old lady who she used to leave her room and go in her daughter-in-law's room and used to pass urine on her bed. So she asked me ki whether she is doing intentionally or not. I'm not able to understand. Then I consoled it. She might be forgetting where the bathroom is. Action of the caregiver is review medicines, treat medical reasons, maintain hydration, simplify steps for going to toilet, simplify clothing, take care of skin if using diapers. Bathroom should be properly lit. If the person is having constipation, then add fiber to diet, avoid processed food, rice and potatoes, regular exercise. Even if the patient is dementia, you have to do some active and some passive exercises. You get it done. Then drinking adequate amount of water is necessary. Always consider patient may forget that he has gone and passed stool. Dental hygiene, patient may forget to clean teeth. Dentures may not be fitted properly. Eliminate sugars from sweets from the diet. Rinse mouth with mouthwashes. Visit dentist every 6 months. Brush teeth twice. If dentures are there, you have to soak them in water. One more reason for getting these dental problems is decrease in salivation. So you have to consider and keep on giving them more fluids. Now, holidays and hospitalization. Uh, Person may become restless if they are going out at a new place. So plan visiting places which they are familiar to. Go out for any celebration in afternoon rather than in evening to prevent sundowning. Avoid alcoholic drinks. Ensure safety and comfort and enjoyment for everyone. हॉस्पिटलाइजेशन अगेन में बी कंफ्यूजिंग सो जितना हो सके पेशेंट को घर पे ही ट्रीट करना है until up till it's a medical emergency and the patient cannot be taken care at home. The person becomes uncomfortable and filled with anxiety due to a new environment and maybe very traumatic for the patient. Stress of illness, anesthesia, and surgery may aggravate all the symptoms. Plan for hospital only if cannot be avoided, and plan an early discharge. A familiar face should always be there in the hospital with the person. Now, this is the ADL scores chart. You can get them on net. इसमें we take consider talking, whether the person is able to chew, swallow, breathing normally, brushing teeth or hair, arising from chair or on it his or herself own, double vision, eye droop. Now these are the scores which are given. ADL score, 8 factors are there. Overall score, patient on the scale 0 to 100. 95 to 100 is excellent. Score of 84 to 94 is also good. 65 to 83 is fair. And if it is less than 65, it's a very poor scale. These again are mini mental status examination. These are the tasks which are given to the patients, like orientation of time. We ask year, season, date, at what place he or she is living, his or her home address, then registration of any 3 words. We tell them any 3 words and then we ask them to repeat it. Then we can give simple calculations of addition or multiplication. Then recalling all 3 words which we have given earlier. Then language naming, language repetition, language commands, language reading, writing, visuospatial skills, copying shapes, then spatial skills of intersecting, then orientation and command. These are the marks. Series of questions to assess cognitive impairment and screen for dementia. Then evaluate person's memory, attention, language, and visuospatial abilities. Maximum score is 30. 21 to 26 is mild dementia. 15 to 20 points is moderate. And if the marks are less than 15, it's severe dementia. Now I'm presenting only 2 cases of mine. This is case number 1 is Urmila Devi. She's about 62 years old and she is working as a maid in different houses in my locality. She is married, having 3 sons, and living in Wazirpur, and no formal education. But she is independent as she is working on her own. Now living with her youngest son and daughter-in-law and financially independent. The only thing is that she is a BD smoker. Now the person complained of forgetfulness. The thing is she is unable to find her way to home and then from home to place of work. She misses the street and not able to find the money where she has kept. She always thinks that the money has been taken by someone or stolen by her daughter-in-law or some neighbor. One day what happened, she thought that her house in Bhavana, and from Ashok Vihar, Azadpur, she took a train and went to Bhavana, and there she lost her way, and then she was looking for her house and she was crying on a road, and one auto driver saw her and he might be recognizing her, so he brought her back. Now caregivers and family members were now worried and came for consultation. These are the presenting complaints. A good worker, her appointer always loved her, pampered her, she loved her work. Problem arose when she started forgetting things, especially about her monthly wages. At first time, family thought it's a part of aging, but when her husband passed away due to COPD, a chronic BD smoker and ganja addict, she was very depressed, sad, but still kept on working. But slowly the capacity to work decreased and she had frequent falls. Once she had fractured scaphoid and she was forgetting her way to home. Her daughter-in-law provided all this history. Then a history of TB at an early age, using medicines for recurrent bouts of cough, likes tea and smoking, takes 2 meals a day, loves eating lentils and rice or fish rice, do eat green beds, loves cold drink, has difficulty in chewing as she lost her teeth. Mind me, she is sad, angry because she always thinks someone steals her money, not able to understand why she forgets the way. She is eldest in her whole family, and she's given due respect for that. And everyone consults her for all the ceremonies and religious issues. All this makes her happy and enthusiastic and takes interest in all those activities actively. Remembers, enjoy singing low gates, angers easily, abuses daughter-in-laws for taking her money. Now, these were the parameters. She was weight 40 kg, 4 feet 10 inch high. This is a BP 160 by 90 and 160 by 60, pulse 65, pallor absent, edema absent, oral cavity, 5 teeth left. Test got extracted after caries. Vision is disturbed. One eye she has got surgery for cataract. Hearing is slightly impaired. Right ear is more affected. Now, ADL score was 80 upon 100 and MMSC score was 20 upon 30. History of fall occasional. Lab investigation B12 levels were less than 200 micrograms. Leukocytes were raised. X-ray chest bronchivascular markings were increased as she's a chronic BD smoker. Slight cardiomegaly was there. Vitamin D levels were low. MRI, temporal atrophy, hyperintensities in hippocampal cortex and gyral hypointense bands were seen. Now, these were the rubrics: forgetfulness, memory weakness, places for known streets, sadness, depressed, history of grief, death of husband, want to go home, abusive, angers easily, brain atrophies, loves singing, desires fish, tobacco, tea, cough spasmodic, expectoration was white, respiration, wheezing, slight wheezing was present. And this was the medicine which was prescribed. Thuja, Lycopodium 30, then Justicia, 10 drops in water, Calcarea sulf 6 twice. And now her complaints were improved of cough and all that, but memory slight deterioration occurred with time. And I think 2 or 3 years back, she passed away. She had a fall and her femur fracture got it done, and surgery couldn't be done because of the changes in the chest. So she was bedridden for last about 1 year. Slowly, the appetite decreased and she passed away. These were the medicine which were given after the first week, second week. So management was B12, folic acid and vitamin supplements were given along with the soft palatable food, low fats and rich protein diet. Smoking and tobacco is invited, and smoke-free environment. I asked her daughter-in-law not to make food on wood. Steam inhalation for improving cough. A family member should always accompany her at the place of work if she is going. An identification help card with address in her neck. Regular exercise to improve bone and muscle strength. Water intake and regular meals. Balanced diet. Clothes according to season. Medication and visiting doctors every 2 months for evaluation. Involving her in singing activities. This is case number 2. She is still living. She came to me around 5 years back. This is Mrs. Kusumlata Sethi, and married. She was a teacher. She's having 3 children, 2 sons, 1 daughter, and now she's retired and have been a socially active person throughout her life. She was diabetic and hypertensive. She was apparently well until 2020. Then she became a bit forgetful as she misplaced things, but the family associated it was part of aging. In April 2021, she had an attack of COVID. The fever remained for 5 days, after which she became restless, anxious and more forgetful. She was sleepless, moved to kitchen every night for cooking food. The noise of utensils from kitchen made daughter-in-law to get up and look for her. She was brought back to bedroom again. Her balance was also affected and she used to fall many times. She is having short-term memory loss, forgetting relationships, anxiety about personal clothes, money in her purse, whether her clothes are washed or not. The family member used to tie her legs at night so that she doesn't move to kitchen at night. Keep on asking time again and again, even when the wall clock is there in front of her. Have anxiety about getting up and taking bath, getting up ready for going to school. In 2020, her husband died due to a heart attack, and she didn't show any emotions and was not able to understand what has happened. She was having tremors and stiffness, also finding it difficult to walk. She thought her son to be her husband and addressed him as her husband. The family's concern took her to the neurologist. All the investigations done gave diagnosis of Parkinson's disease with dementia. Now she is also giving. She is her daughter-in-law is also giving history of dementia to one of her sisters also. Now blood sugar fasting was 140 milligram percent. HbA1c was 7.2. Blood pressure was 180 by 100. Vitamin B12 levels were around 344. Vitamin D levels were normal. MRI showed age-related atrophy and widespread chronic ischemic changes. ADL score was 60 upon 100 and MMSC score was 12 upon 30. Now this is the CAT scan. On reporterization, dementia senilis, forgetful old people, forgetful words while speaking of, restlessness, night, bed driving out of, trembling hands, stiffness, incoordination, paralysis agitance, indifferent apathy. This is the reporterization. Medicine prescribed were acid phos 200 weekly, acid phos 200 twice daily, Thuja 200 weekly dose, and then Brahmi 10 drops for a month. Management is an identification card should be used. Control diabetes and hypertension. Avoid foods with sugars and fats. Do low salt diet. Adequate water and balance rich in antioxidants. Physiotherapy and exercise for improving balance and use of walker to avoid falls. Involving her activities such as gardening may prevent further deterioration. Now, rehabilitation may require multi-dimensional approach, medicines, physiotherapy, counseling of patients, caregivers, support of society. Now, all the caregivers should keep all emergency numbers with them. Taking care of an elderly is same as taking care of a kid. Now, this is the physiotherapy session. A physiotherapist is coming to help her make walk. She was walking with the walker, and now they are coming on stick. Abhi recently last week, this same patient, the daughter-in-law came to me and said that she's not eating and the caregiver is forcing her to eat food. So she might be having some pain in throat and she's coughing also. And she's having slight fever also. So I prescribed, I have not written all that in this presentation. I prescribed some medicine for her fever and so thinking that she is having some acute viral infection. And the daughter-in-law, after 2 days, she again came ki cough काफी निकला है, white discharge. She has given off slight improvement in food, but still she's not eating up to mark. And I asked her, so she's normally she is not telling what are her complaints. She spoke कि मेरा बहुत बुरा हाल है. This was the only words which she spoke. Then I advised her to give her semi-solid diet and get a CBC and urine report tests because low-grade fever can be because of UTI, because she's still wearing diaper and some because of some unhygiene. It may be possible that since she is a diabetic, the person may develop UTI, and the same thing happened. In urine, there was acute infection. Then I gave medicine for UTI, because in such patients, because of dementia, they are not able to tell the what complaints they are having. So doctors have to judge. And now the fever has come down. Today only the daughter-in-law came and she said now she is better and comfortable. So these are the challenges for doctor. Taking care of a person having dementia is not challenging for caregivers, but also for the doctors. So she is already taking some medicine for Parkinson's, but I think it has become a bit static. But uh, बहुत इम्प्रूवमेंट ऐसा कि नहीं है, केयर गिवर रखा हुआ है उनको देखने के लिए. And thank you all for watching to whatever I have spoken, and I think जो कुछ मैंने बोला है, it will help you all.
Thank you so much, Dr. Kavita. It was wonderful, and especially the management part. Yes, we have to be very careful while we are advising and giving the medicines. Dr. Mukesh, I would like you to, sir.
Thank you, Dr. Kavita. Actually, it was a very useful session and was very honest also, because you never said that you are given the medicines there and there were wonderful improvement and this and that. You said what was the reality. Second, uh, you have whatever medicines you have given, you have listed them all and not claimed that I am the homeopath who prescribes single medicines and single medicine and gets very good results and all that. So that was very good. And this field actually requires lot of work to be done. You have done a lot of work, I agree, but I just want to know whether you had to make some changes for case taking, because that you said was a difficult part. So what are extra efforts you have to make for homeopathic case taking in such cases?
सर आपको जो है एक्टिवली पेशेंट को देखना पड़ेगा, और आपके माइंड में पिक्चर होनी चाहिए अल्जाइमर्स की या डिमेंशिया की. क्या पेशेंट क्या ऐसा अगर बिहेव करे तो क्या वो फील कर रहा होगा, बिकॉज वो तो आपको बता ही नहीं सकते पेशेंट की मुझे यहाँ दर्द है या ये दिक्कत है या गले में दर्द है. आप अगर आपको एक्स्ट्रा केयरफुल ऐसे रहना, अगर पेशेंट को यूटीआई है या निमोनिया हो रहा है तो वो सिंपली खाना खाना छोड़ देते हैं. दे विल डिक्रीज देयर एपेटाइट. एंड हम लोग क्या कहेंगे, हम कहेंगे चलो जी एपेटाइट डिक्रीज हुई है तो उसकी दवाई दे दें, कुछ मल्टीविटामिन दे दें. रादर देन गोइंग फॉर दैट वी शुड थिंक ऑफ द कॉज व्हाट माइट बी देयर, एंड क्या क्या होती हैं कॉमनली. से यूटीआईज हो जाते हैं, निमोनिया हो जाता है, इस टाइम पे पेट में इन्फेक्शन हो सकता है, कोई बेड सोर्स हो सकते हैं. आपके माइंड में वो पिक्चर होनी चाहिए ताकि आप जज कर सको कि अगर पेशेंट नहीं भी बता रहा तो भी आप जो है उसको मतलब ट्रीट कर सकते हो, या मेडिसिन किस तरह से सोच के. अगर ये एक दो दिन में अगर आराम नहीं आ रहा तो आपका दिमाग चलना चाहिए कि इसके पीछे क्या पिक्चर हो सकती है, क्या रीजन है जो हमारी दवाई एक्ट नहीं कर रही है. कैन इट बी दिस, कैन इट बी दिस. वन शुड हैव दिस थिंग व्हाट आई फील.
आई
और
गॉट यू. हाँ, बोलो बोलो.
बल्कि अभी जो ये पेशेंट का मैं यूटीआई का बता रहे हैं, मतलब वो उनकी डॉटर इन लॉ भी डाइटिशियन, एंड शी इज सिटिंग विद वन ऑफ द एंडोक्रिनोलॉजिस्ट. सो शी वाज सरप्राइज्ड. शी वाज सेइंग उनका यूरिन सैंपल लेना मुश्किल हो रहा था, बिकॉज नॉर्मली तो वो डायपर में होती हैं, तो लेंगे कैसे यूरिन सैंपल. देन आई आस्क्ड हर, यू मेक हर ड्रिंक लॉट ऑफ वाटर एंड मेक हर सिट ऑन द चेयर एंड देन यू गेट दैट सैंपल. इस तरह से सैंपल लिया गया. सैंपल लेना भी कितना मुश्किल है, आप ये सोच के दो.
मैं आई एम गेटिंग योर पॉइंट. माय क्वेश्चन इज कि जैसे आपने वो बताया यूटीआई है, अब
हम्म.
यूटीआई में पहले तो मेरा क्वेश्चन ये होगा आपने क्या दवाई दी, मैं फॉर एग्जांपल
सर
बोल.
मैंने अभी इसमें यूटीआई में एसिड नाइट्रिकम और चिमोफिलम अदर टिंचर दिया था.
हाँ, मैं
और
अब यही जानना
मैंने
चाह
तो
रहा हूँ.
यही दी. हाँ हाँ
हाँ,
हाँ.
कैसे
और आई
डिसाइड
आस्क्ड
हुआ
हर
कि.
टू कंट्रोल द डायबिटीज. दैट इज मस्ट, बिकॉज वो
हाँ,
डायबिटीज की वजह से भी जो है ये एग्रेवेट हो जाता है. तो उसके बाद फीवर जब कम आया, और दोबारा जो नॉर्मली क्या है, मैं ऐसे पेशेंट्स का ना कोशिश यही करती हूँ कि दोबारा एक बार कल्चर करा लिया जाए. अगर तो वो नेगेटिव आ गया, पस सेल कम आ गए, फिर तो मैं मान लेती हूँ कि बेटर हैं और ठीक है। क्लिनिकली साथ में करना वो जरूरी है सर। आप ऐसे हवाबाजी नहीं करो।
मैं मतलब यही जानना चाह रहा हूँ कि मतलब जैसे ऐसे केसेस में आपको क्या एफर्ट करना पड़ा कि आप डिफरेंशिएट कर पाओ कि कैंथारिस नहीं देनी, नाइट्रिक एसिड देनी है, या
सर
हाँ कुछ
सिम्टम
भी।
तो सिम्टम तो
सिम्टम
कुछ
तो
सर
मिलते ही
दे
नहीं।
नहीं रहे ना
यही मैं जानना चाह रहा हूँ कि आपने क्योंकि काफ़ी काम किया है, तो कैसे आपने किया है, मैं यही जानना चाहूँगी। ये बड़ा डिफिकल्ट लग रहा है मुझे इनमें के
हाँ ये
सिम्टम्स
मुश्किल है
लेना।
सर, ये मुश्किल है, बिल्कुल है। ये दवाई तो अंदाजे से, बिकॉज सिम्टम तो दिया ही नहीं, वो तो घर वाले तो
जी
मानने को ही तैयार नहीं थे कि यूटीआई होगा।
जी। अच्छा,
हाँ
ठीक है। पर बहुत अच्छा था आपका। पर आप इस पे और काम करो। हम एक चाहेंगे कि आप पूरा जीरियाट्रिक्स की केस टेकिंग को कैसे इम्प्रूव किया जा सकता है, इस पे कोई पेपर आप हमें बना के दो तो
हाँ
हम,
सर, कर रही
है ना?
हूँ, करूंगी।
हाँ जी।
हाँ जरूर करूंगी सर, करना
थैंक्स
है,
अ
कर
लॉट।
ही रही हूँ रादर। डाटा भी
हाँ
इकट्ठा कर रही हूँ, पेशेंट्स भी,
जी
और वर्क कर रही हूँ,
जी।
कर रही हूँ सर।
थैंक्स अ लॉट, बहुत अच्छी थी प्रेजेंटेशन
थैंक यू
आपकी।
सर।
थैंक यू।
Thank you so much, ma'am. Thank you, sir.
थैंक यू।